a consultant. Oh, sorry that. Okay. So, and I work as a consultant in anesthetics and pain in the Huelda NHS Trust in Wales. Now to conclude, this is quite a large topic and it's almost going to be like a nutshell, and we have to proceed quite fast so that I can take you right from where anesthetics started and to where we are now. So to start off with, what do we mean by the word anesthesia? It is a Greek word and it means without sensation. This was coined by Oliver Wendell Holmes in the year 1846. And the main thing is that it is controlled, it is temporary, it is a loss of sensation or awareness, and we do it only for medical purposes. It includes a lot of components, which are analgesia. You want the patient to be pain-free. You need paralysis of the patient because the surgeons want to operate, especially when we are talking of intra-abdominal operations. The surgeons need to go into a cavity and they need to approach the organ which they are targeting. So if the tone of the muscle, especially the abdominal wall, if it is tight, it's difficult for the surgeons to operate. So we make it convenient and make it easy sort of for the surgeon to do their job in a better way, rather than fighting the muscles and the other things, trying to close the abdomen down. And also for the patient, they don't want to remember or know anything. So our agents give them amnesia. So they forget, they just don't remember what happened. It's almost as if a small part of their lives, they have no recollection about. And also unconsciousness during the procedure. Nobody is going to let you operate if they are awake. You need to have them asleep, especially when we talk of a general anesthetic. And the end of it, when the whole done, we want it to be reversible, so we can reverse all our agents that we have given for the procedure, and we can wake up the patient in a comfortable manner, ready to recover from his. Now, when we look at the different types of anesthesia, as I mentioned, all those components we read in general anesthesia. And the other thing which is very common is a central neuraxial block. This basically means that we are injecting our anesthetics into the spinal fluid around in your spinal column, especially in your lumbar region. This is called the spinal, and it is very popular for procedures that we do from the umbilical downwards, where seals, for cesarean sections, and for orthopedic procedures, hip knee replacements, etc. Epidural is a variant of a spinal. But now as we have moved on, we have to recognize that why should we put our patients asleep? Now we happily do trauma surgeries and procedures, like somebody has come in with a crushed hand in a factory or somewhere. We feel that really we don't need to make the patient asleep. We can just give a regional block, just block the hand. So nowadays we have moved on to regional anesthesia, where we just block the hand. We would give sedation to the patient so that the patient is comfortable, and in a way he doesn't mind all that the surgeons and all are doing and operating his hand. So now that is where we are going on, that we are becoming more narrowing down the focus of anesthetics to where the operation is. And local is something which the surgeons now, they don't even need an anesthetist, they themselves, but these are really very small procedures and just superficial procedures which they can do without the presence of anesthetist. Otherwise, always they like to have the support from the anesthetic colleague, because we can jump in and add on to our techniques and, you know, make the procedure possible for the surgeons to do. So these are the types of anesthesia, but today we are talking mainly of general anesthetic. So here in my next slide, I'm going to tell you about stages of general anesthesia. This is mainly when in the beginning we were using ether and we were using volatile agents as a sole agent for anesthetizing the patient. So the patient goes through different stages as they transfer from an awake state to an anesthetized state. So the stage one, once we start administering the anesthesia through a face mask, it's almost like a net, like a mesh through which we used to pour our anesthetic agents. I remember that is how I started my anesthetic training, but now those days are gone. Now we no longer use ether and we no longer pour anesthetics on patients' faces anymore. But from stages have come out, and we say the stage one is from the induction of anesthesia to the loss of consciousness, which we checking the eyelid. And if there's a blink, that means the patient is not deep enough. So we keep on pouring our anesthetic agent till the patient stops that reflex. But in the stage two, that patient is a bit agitated, there is delirium, the respiration is a bit rocky, and the pupils are dilated. It is an uninhibited excitatory state for the patient. And also they can have movements of breath holding. So, but we just have to carry on and we have to pass through this stage and go to the next one, which is the stage three, which is anesthesia, where we find that the pupils and the eye, they become central, the respiration settle down, they become regular, and realize that the depth of anesthesia is sufficient, such that when we teach the patient, that is our check, the patient does not elicit any reflexes or does not react. And there is no autonomic reflexes. By autonomic reflexes, I mean any change in heart rate, blood pressure, like that, to alert us that probably the patient is not deep enough. Now this stage can be divided into 4 planes. So the first plane is when the respirations are regular till the cessation point. And the stage 2, the plane 2, is time movement in the eye is settled to the onset of the paresis of your intercostal muscles, that is your chest wall. And the third plane is when the chest wall muscles are completely paralyzed. And the plane 4 is when from the intercostal muscles, the next and the final muscle to go is the diaphragm. So any effort of breathing from your patient is no longer there. Now, if we continue to proceed with administering more anesthetics, we come to the stage 4, which is an overdose stage, which is a possible impending death. Now here's apnea, the pupil dilated, and now find the circulation of the patient begins to fail and they become very hypotensive. So this is where we are constantly monitoring a patient to know that he is sufficiently deep, but not more than what is required. So now we find traditionally what we do nowadays is that we have stopped all those methods from the past. Now it is like now. We pre-oxygenate our patient. We always give oxygen minutes before we start the anesthetic. Then we give pre-medication, which is a combination of opioid, anesthetics, and some benzodiazepines, so that the patient is pre-medicated and he's calm. And then we start giving our intravenous agents, which is given like a bolus. And as we go through time, we can see that previously we have thiopentone, which is very popular in the whole of the last century, really. And it has only been replaced now by propofol. So thiopentone is an ultra short acting barbiturate. It is onset of action very fast, 15 to 30 seconds. And by 20 minutes, action is over. So very good. It is very cardio stable. And people who have got unstable, like when you are in an emergency, you have a patient who has had a trauma, who has probably lost a lot of blood. So he's sympathetically overactive, he's volume depleted. And in such a condition, we need to be very careful with the amount of anesthetics or induction agent we give. Now, propofol has come. It has come towards the end of the 1990s and very common here. And I believe in India as well, it has just taken over. And the biggest advantage of propofol is that it causes you rapid onset, rapid offset, and clear-headedness. The patient wakes up clear. There is no being asleep for days or being muddled, you know, that sort. So that is why propofol has taken over thiopentone. And after that, we have got etomidate, which is a very cardiostable drug. Once again, very useful for emergency conditions. And after that, the ketamine, which is an NMDA antagonist. The thing about ketamine is that it increases your heart rate. It has effect on the heart. So not suitable for people who have got a high blood pressure or such sort of a comorbid conditions. So you have a choice. When you do your pre-assessment and you see your patient, you go through all their comorbid conditions. Are they hypertensive? Are they diabetic? Have they got any renal or liver or any such issues? So all of that helps the anesthetist to tailor-make his choice. Now it is intravenous agents, the patient are just as you give the injection, the patient just drifts off to sleep. So the next thing we see here is that what are the possible complications that can happen from these drugs? Thiopentone, the main thing about it was that it is a very strong alkali and it can extravasation, if it leaks from the vein or the vein by any chance, you know, ruptures or there is an issue, if it goes around the periconnective tissue, it can cause necrosis, local necrosis in the skin. And if by chance, God forbid, if somebody puts a cannula in an artery rather than a vein, and then gives the thiopentone, then this is going to be a big major problem because thiopentone crystallizes and it blocks the blood supply to the periphery of that limb. So it can lead to severe vasoconstriction, causing gangrene and loss of a digit or a hand. So this was the main things. I think when propofol came, everybody breathed a sigh of relief and said, at last now we don't have to worry about such a consequences. So we have to keep on watching ourselves. And as we work in an anesthesia, we work as a team. So everybody is watching each other so that we are constantly making sure that nothing is going awry and we're not aware of it. Now, that was the issue with the thiopentone. And of course, if such a thing happens, you have to be prepared. There is a protocol in place, what to do if such an untoward incident has occurred. Now, when we go to propofol, the thing is that now that propofol has come in the market, people have started using it for longer and longer and longer procedures. Sometimes if you're not careful about the dose, you find that it can lead to a condition of lactic acidosis for the patient. So constantly, the moment you give an agent like this, you need to be monitoring, you need to be doing blood gas analysis, checking what are the acids produced by the patient, is there syndrome of lactic acidosis, and we have to treat it. So that's the problem with propofol. Now with etomidate, the biggest problem was what people found, that even with a single dose of etomidate, it's just the adrenocortical rifts. And as we all know, even for our day-to-day activity, we need to have sufficient amount of steroids. So our body produces around 30 grams of steroids roughly a day. Now this is lost after giving this agent. So if you're going to give etomidate, you've got to ensure that you are topping up and you are providing the steroids that you need. So as you can see, every agent has got something, and something you need to watch out for, and something you need to ensure does not happen. And the last thing, ketamine. The biggest problem with ketamine was the emergence delirium. That is, the fact is that the people, when they woke up, they were hallucinating, they were seeing things, they felt very uncomfortable. So it is like dreams, really. And it's from person to person, what sort of dream he wakes up with. So that has led to ketamine not being used on a routine, regular basis. And then opioids, very rarely we use it as an agent for induction on its own. It is always used as a component of anesthetics. Opioids, as we know, is morphine and the derivatives of morphine. Nowadays in our lab, we have produced a variety of opioids, which is fentanyl, alfentanyl, sufentanil, remifentanil. So people have gone on improving the amount of opioids and its properties that you can use for your anesthetic. So this is just a brief thing about the intravenous agents that we are using. For the induction, the other agent that we can use is inhalational. Like, as I mentioned, that ether was something which I started out my anesthetic career with, and now it has moved on to other much more better agents. Where would we prefer to use the inhalational induction agents? Mainly young children, who is not going to let you put a cannula in their hand. It is always going to be a struggle, and you have to anesthetize young children, be it for a tonsillectomy, or they have come in for maybe circumcision or any such procedures. So what you would do is you would use an induction agent, that is breathing. So you just put the mask in front of the face of the child, and the child breathes through the mask, and they drift off to sleep. The other reason where you would use is upper airway obstruction, especially in children if they've got a swelling in the throat. So in that, we don't want to give any intravenous agent. We want the child to continue breathing. We feel if the child is continuing to breathe, the airway is patent. So to keep that in mind, if there's an airway obstruction, our first choice would be give an inhalational induction, so that the child breathes through and sleeps. And then we can do what else we need to do. Now, suppose we have got a situation in an adult where we know that this airway is going to be a difficult airway. If I paralyze the patient, I could be in trouble. I may not be able to secure the airway. In that case, again, I prefer to keep the patient breathing spontaneously, so that there is no such issue of me being faced with a man who is, not breathing and I'm not able to secure. And those unoperative resistant patients who don't understand, who have come for dental procedures, who have got mental issues. For these patients also, we find that giving an inhalational is possible rather than trying to put a cannula in place to give the intravenous agent. And of course, last but not the least, the patient who is scared of needles, who are needle phobic. They won't come anywhere near them with a needle. If whatever you tell them, they're going to say, I'm not having a needle. So for these patients also, we offer that the gas induction. So they can hold the mask in their own comfort, and they breathe the gas and they can drift off to sleep. So these are the indications for inhalational induction agent. Now this just leads you to the history. Where did we start? I mean, like, it started, as you can see, quite a few hundreds of years ago. 1540 was the time when ethyl ether was first discovered, created by Valerius Cordus, a German scientist. TIVA was also known as the sweet oil of vitriol since the 12th, 13th century. It was known by the chemists at those days, but its properties as an anesthetic was not understood at that time. And then you see 200 years later, 1773, Joseph Priestley, he invented nitrous oxide, which is the laughing gas. It was in those days being used in the parties for people just to have a bit of laugh and a giggle and, have enjoyment that way. So that's where it was being used. It was only in 1885 that Horace Wells, who was a dentist, he observed in one such party that a man had this nitrous oxide, inhaled this nitrous oxide, and then he fell down. He injured his knee quite badly, but he didn't have any pain. So that triggered this observation. Oh, I can use this for my dental patients. So what he did was he got his own tooth extracted after that, and he felt no pain. So he was very much impressed. However, he went to do a demonstration of the use of nitrous oxide for pain relief, but the patient, when the tooth was coming out, the patient cried out in pain. Later on, the patient did not remember the incident, he did not remember any pain, but at the point the tooth came out, he shouted in pain. So that was booed and people called him a humbug, and the whole thing was thrown out and people didn't believe in it. We think now that probably at that time whoever was administering the nitrous oxide probably did not have the patient deep enough to obtain the analgesia component. Now we know that tomorrow is going to be our World Anesthesia Day. It's the 16th October. This day is important because in 1846, it was William Morton who did his first demonstration of the use of ether for a painless, extraction. So here he has done an excision of the neck tumor in the Massachusetts General Hospital. They have kept that place as it is, and it is now called the Ether Dome, where first anesthesia was administered successfully and the surgeon was able to do this procedure. So when William Morton died, on his tombstone, there is a very lovely little epitaph that they have put there, which says, "For whom in all time surgery was an agony, by whom pain in surgery was averted, since whom science has got control of pain." So you know that this is a very, very important day for anesthetists, and all the world over, we remember this day and we remember the contributions of this great man who just changed the direction of surgery operations. Around that time in the 1846, 47, 50, many agents started coming out. And there was an obstetrician, Dr. James Simpson. He realized that chloroform could also be used as an anesthetic. And he did use chloroform for quite a few of the obstetric patients that he used to deal with. And in 1853, Dr. John Snow, he gave chloroform to Queen Victoria to help her with childbirth. In those days, they used to just have a rag cloth and they used to soak it in the agent and the patient used to breathe from it. So there was none of the things that we have now, but that was how it all started, simply by a rag cloth. And after that, they went on to have in a bottle with the rag cloth inside the bottle, a bit of a constriction at one end through which the patient breathed. So from one end you would get air in and you would get the volatile agent evaporating and the patient inhaling. So that was how anesthetic started. Now this is just a list. I know it's a lot, but I'm trying to cover a big topic in a short time. So here you can see that ether came out in 1540, nitrous oxide 1773, chloroform mid-18s, 1850, then cyclopropane came out in 1929. Cyclopropane is very effective anesthetic agent. It sends people off to sleep by just 2 or 3 breaths, but it is very inflammable. And there had been incidents where there was catching fire in the theater. So it went out of favor. And then halothane came in 1951. It was also very popular. When I started out, we used to give halothane induction for all children. But the only problem with halothane is that it has got cardiac arrhythmias problem. And if you're not careful, you can have a heart which might give lots of different sort of dysrhythmias and can also cause severe bradycardia. So a bit of a challenging and quite a stressful induction of anesthetics. So that has gone out of favor now. We don't use halothane anymore. Now it is replaced by agents like isoflurane, sevoflurane, desflurane. Out of this, sevoflurane is the best for inhalational induction because it's very pleasant to breathe, and you can quickly deepen the anesthetic and the patient goes off to sleep, bypassing all those stages, especially the stage 2, as we said, of uninhibition, shaking, kicking, and all those stages are passed. Isoflurane is good for patients with cardiac problems, and desflurane is more stable in terms of anesthetics, which we use now. However, the problem with desflurane is that it's pungent, and nobody is going to breathe the desflurane because it will make them cough, and that would be counterintuitive if you're trying to drift anybody off to sleep. So this is where we are now. Now, inhalation agents are good, but they have their own complications. And what is the complications? As compared to an intravenous agent, it is slower onset. Some agents, if we try to use, can still have problematic stage 2 of anesthesia. Anything can happen. It can cause bronchospasm, it can cause laryngeal spasm, you can get hiccups, you can get airway obstruction. So all these things we have to manage. And the worst thing, which has come to light now, that all these volatiles are actually causing an environmental pollution. They have found that it is responsible for 5% of the carbon footprint. And in this day and age where we are very concerned about preserving and saving our earth, we know the importance of carbon footprint. 5% we think is a very small amount compared to all the other agents that people are using. But it adds, it can add on, and it is cumulative. And as you can see, it can cause ozone depletion in the stratosphere and a greenhouse warming in the troposphere, which is not good for the earth. So from that point of view, we have now tried to move on to other ways in which we can give anesthetic to a patient, which is safe for the patient, safe for the personnel, because this breathing of the volatiles for the anesthetists and the surgeons in the theater, you are in that environment day in, day out for 30 years, 40 years of your life. And this can also have complications for your general health. The main thing with halothane which came out was halothane hepatitis, which actually mainly if the patient comes for a second anesthetic or a third anesthetic, then hepatitis has been recorded. And same for the women anesthetists. They had a more incidence of abortions and these sort of issues because of the constant breathing of these volatile agents. But now we have changed it. Now we've got a system of scavenging. Whatever the patient breathes out, we suck it out and it goes through a pipe and it goes out into the atmosphere. But then there the problems, environmental pollution comes to play. So currently what we do is we give our induction agents. Very quickly the patient is going to the stage 3. Then we give muscle relaxant. We intubate, we put a tube into the patient's air, and with this, and once we have secured the tube in the patient's trachea, then we ventilate the patient. So now the patient is anesthetized, he's hypnotized, he is got the tube, and we maintain the anesthesia with the volatile agent and opioids, and we keep him deep for the procedure, operation to happen. And at the end, we reverse the muscle relaxant. So the muscle relaxant she gave, we clear it out. and then we lighten, we reduce our volatiles, and then wake up the patient so that he's comfortable and pain-free. So this is just a very small gist of how anesthetic is done currently with intravenous method. Now, when we consider that we have got a whole sort of patients, like suppose we have got an elderly patient. Now, these patients have got lots of comorbid conditions. They're all hypertensive, they've all got diabetes, they all have got other issues, maybe a kidney problem or a liver problem, and we have to keep that in mind. And we also know that the circulation time is slow. So we have to give our agents very slowly for these patients so that we don't overdose them. So you have to be very careful. Similarly, when you've got a pregnant patient who comes, normally we would not do any elective procedure for a pregnant patient. But suppose she comes in for an emergency surgery, then we have to anesthetize, because always the mother comes for the baby, the mother first. So in that case, we have to explain to the patient that our anesthetic can actually either cause an abortion or it can cause a premature labor. So this information has to be informed to the patient before you anesthetize them. And suppose patient has now come for an elective cesarean section, which for some reason we can't do under a spinal and we have to give a general anesthetic. So the way we do our anesthetics is that we avoid giving any opioids for till the baby is out. Because otherwise what will happen, that through the mother's blood circulation, these agents go to the baby through the uteroplacental passage of drugs, and then the baby wakes up depressed and the breathing is slow. And then we have to observe the baby, we may have to give oxygen, etc. to the baby. So if you're giving a general anesthetic for a pregnant woman for cesarean section, you have to tailor your anesthetic such that you give the opioids, other things only after the baby is born. So you have to keep that in mind. For our pediatric patient, it is usually our inhalational induction agent. I know that in India, when I was training, we used to also give ketamine as an intramuscular agent before, so that the child goes to sleep in the arms of the parent and the child is asleep as we take them to theatre. But this is not a popular practice in the UK. In the UK, we will just get the baby along with the parent to the anesthetic room, and we will give the inhalational induction agent and drift the child off to sleep in the parent's arms. That's how it is, anesthesia is conducted here. Now, this is just to give you a brief idea of how the anesthetic machine looks like, and how you can see here that we have got lots of monitors. We are constantly monitoring the physiological parameters of the patient. We check out their ECG, we check out their blood pressure, we look at the oxygen saturation, we look at the respiration, we look at the flow volume loops, and we keep track. And also, if we want to do further, we can do further monitoring depending on the case or how sick the patient is. As you can see, we have got very fancy monitors over here, very fancy vaporizers, and you can see the green bag, that is the bag through which we ventilate our patients. But nowadays, from this bag, we change it into a ventilator, a spontaneously ventilator which will carry on. When I trained, we had to manually bag the patient and ventilate the patient. But now it is all done electronically, and we don't have to, we just have to put the patient, connect them up, set our parameters, and then we just sit and observe and make sure that the patient is keeping well and there is not undue blood loss or he's not getting hypotensive. And constantly we are changing our anesthetic as the procedure goes on. Right, so now we are coming to what is a newer induction technique, how we have moved over the times. Now, newer induction technique is a balanced anesthesia where we give the anesthetic and we are only giving intravenous, only intravenous. We have moved away from the vaporizers, we have moved away from the volatiles. Now we are giving an agent, which is usually propofol or opioids, which is hypnotic, so the patient is unconscious, and is analgesic, so the patient is pain-free. And now the new term has come, vapor-free anesthesia. We don't want any more vapors, however good they are, because of the environmental pollution. And this is where we have to head now. Now, TIVA. TIVA is the buzzword. It means total intravenous anesthesia. What are the advantages? It has got a rapid onset, and you shut it off, you stop your infusion, and patient wakes up clear-headed because you're using propofol, and we can use it for as long as we want, maybe 6 hours, 8 hours. It does not really matter. You can continue for a long time, but the patient still wakes up clear-headed. It does not cause any nausea or vomiting. It has got no organ toxicity, no liver, no hepatitis, no problems. The stress response to the patient is less. The side effect of nitrous oxide, which is basically nitrous oxide side effect, is that makes you feel very sick afterwards. That is gone. And also now suppose a patient has come to the emergency A&E and he has had a head injury, and the surgeons say, we want to see whether he's got blood, some, blood clot in the head. So we have to take the patient from the A&E to the radiology department, where we will do the CT scan of the head. So in such case, where you are transferring patient from one area to another, you cannot physically take your anesthetic machine along. So in this situation, we go back to our intravenous agents. We have our special pumps, we put it on a stand, and we monitor and we set our parameters that we want, and we take the pump along with us to the CT scan room. So it is useful. You can use it as a transit in remote locations. And also if you are in a battlefield and you have to transfer patients, once again, you'll put up the patient to these infusion pumps, which you can take along with your patient. And most importantly, no environmental pollution at all. And it is safe in patients with malignant hyperthermia. I know I'm introducing new words, new terms, but these are things which we have to keep in mind. Now, malignant hyperthermia, all the volatile agents can trigger the patient who has got the propensity to have this disease, can trigger a reaction causing malignant hyperthermia. And that you avoid by using the TIVA. What are the disadvantages? The disadvantages are that once it is given, you can't take it back. We are using propofol, and propofol can cause pain on injection. So if you're going to use it for a long period of time, you might find that the vein is going to get irritant. Venous irritation can occur. You need these special pumps, so you need special equipment. And the main thing is that you have to use another monitor called the bispectral index monitor, where we monitor the brain waves. And that is the only way which we can know that the patient is actually asleep, he's not aware, because otherwise you don't want to give less amount of the dose and you find that the patient is aware, which is probably a very uncomfortable situation for the patient. And it can also be put in the category of a clinical negligence on the part of the anesthetist if he does not keep his patients asleep for any procedure or for any location or transfer. So we have to use the bispectral index. In the UK, it is like an important, it is in the protocol. If you're going to use TIVA, you have to use a bispectral index. If you don't have the equipment for bispectral index, you have to make sure that you've got other things in place before you administer a TIVA safely. So all this adds up. So it is still very expensive. still very expensive than our traditional induction methods we have seen till now. Now, this slide is basically just telling you that you give the dose, goes to the blood, straight into your system. From the system, it gets metabolized, it gets excreted renally, and it's redistributed. It goes into the vessel rich, that is your muscles, and your level of concentration of your dose goes down. It also goes into the brain, which is the effect site concentration. There is also the drug receptor interaction, and you get the clinical effects of hypnosis and analgesia. This is how the TIVA works. Now, TCI, the target controlled infusion. Now, this is a step forward from the TIVA. In this TCI, we see that it is user controlled. That is, the anesthetist, he controls the amount of drug concentration in a body compartment at all times. So if he puts it that I want the amount of propofol at this level in the blood circulation and fixes it, then you find that the microprocessor which is installed in that pump will ensure that that is the amount that is present in the patient at all times. So it is very complex. It is a multi-compartmental pharmacokinetic model, because we know that amount of drug is constantly changing. It is getting metabolized or going out by the kidney, so that is why we have to make sure that the level is there. And this is the new thing. This is the target controlled infusion, which keeps our patient asleep at the point where we want them to be. What does it cause? It causes amnesia. What do we use? We use propofol. What models do we have? We have models called the Marsh and the Snyder model. In the UK, it is the Marsh model, which is the most popular. And it is the Marsh model that we have incorporated in all our machines, so that when we put in our parameters, we ensure it through that calculation. And the other thing, as I mentioned, we give propofol, and we also give opioids. We give a combination. So combination of opioids, these are morphine derivatives. These are fentanyl or enfentanyl or remi or sufentanil. Now, these are another topic in itself. How much do you give? What would be your choice? Again, it is all tailor-made. It is all tailor-made to your patient that you have. What would you prefer? We are fortunate in the UK that we seem to have all these drugs. The only drugs not available is the sufentanil. But we have got fentanyl, alfentanil, and remifentanil, which helps us to do really sick patient and elderly patients even up to the age of 90 plus, turn up on our theater operating list, and we would anesthetize them. So as I said before, TCI for long procedures, breast reconstruction after mastectomy, quick onset, offset despite prolonged hours. It is safe. Patient wakes up clear-headed. It is safe for the personnel. There is no volatile, no side effects, no risk of long-term gas inhalation. So this is the way forward. That's where we are heading now, towards total changeover from the previous to the newer technique now. And here it is. I hope I was all right. I know it was quite rushed, quite fast, and I know it's a lot of information, but I'm ready to answer any questions or doubts that you may have. Thank you.
Yes, ma'am. Thank you so much. That was indeed a thought-provoking and an insightful talk. Now, I would request the participants to kindly ask questions. They can either raise their hand, I can unmute them, or you can ask in chat section as well. Any questions? There is a question. How do you deal with the mental cases, like the mentally disabled patients in case of anesthesia?
Yeah, as these are really challenging patients. And to be honest, we call it our mental dental list. It's just like a bit of a joke, you know. So these patients, they come up, they're usually teenagers, they're adolescents, they have very bad teeth, and the dentist can't cope. They will not let them do any work on their tooth. So they need anesthetics. So we make sure that we are in our, you know, like a day case, it's a day case, but we have to make sure because these patients can't understand anything. They will be coming in, if you're not careful, they'll go in from one door, they're going out from the other door. So you need help. You need to make sure that you've got people who will bring him, who will chat with him, make him sit down, and then you have to talk to him. So it's like, it's not just anesthetics. You have to develop your social skills as well. And you have to create a rapport with the patient. And the only way to do it is to give him the gas. And if he is okay, you know, you have to be polite, you have to be, you know, appreciative of their, you know, drawbacks. But then you need strong men, you need strong anesthetics who can hold them. And then you put the gas, and with the sevoflurane, within 3-4 puffs, they are asleep. So you have to be ready, and you have to be prepared, because they are not going to cooperate. They forget cannula. There's no way you'll get a cannula in such a patient. There's the only way to do is gas. And in the UK, we don't use ketamine. But I'm sure in India, my colleagues may be all probably giving them a shot of intramuscular ketamine or something, at least just to kind of calm them down a bit. But here, it is not popular. It is not the done thing. But we manage, because we want them, once they wake up, we want them to be absolutely awake so that they can get up and, you know, go. So that is how we manage these patients.
I had a question as well. So, are there any drugs to like avoid before the procedure starts, like or general anesthesia starts? Like any drugs to avoid before that?
Yeah. When we do nowadays, we have got a whole pre-assessment clinic. So before a patient is put in on the slot for an elective procedure list, they would go to the pre-assessment. We have got nurses now who do it for us. So they will go through all their medical history and everything, you know, from before. So they will come to all the medication that they are on. So you find that these patients are on all sorts of things, and many of them have got interaction with our anesthetic. The most important one is, like, you know, if they are on warfarin, which is an anticoagulant, which they are probably on for their cardiac conditions, or also because they've got atrial fibrillation or some such condition, but we have to stop the anticoagulant at least 5 days before, because there is no point in the surgeon starting the surgery and then find that he can't stop the bleeding. So that is why we stop the warfarin 5 days before. And nowadays we have got a bridging therapy. You stop the warfarin and you stop and you start another anticoagulant, which is the low molecular weight heparins, which are the synthetic ones, that is the enoxaparin or tinzaparin, and you give it the day before, and you have at least 12 to 24 hours gap before you start the surgery. That's one thing. The other thing is your diabetic medication. If the person is on insulin, you can't be on insulin, you know, because we keep them fasting. We have to keep our patients fasting from midnight. So the way we do it is that we have got the whole medication they are taking, and we give them a list that please don't take this. Like suppose they are on antihypertensive drugs like ramipril. Ramipril, along with our anesthetic agent, causes a severe fall of blood pressure. And then we are struggling to manage the blood pressure intraoperatively. So there are few drugs we tell them, please stop, don't take it. There is a whole list of drugs that we would say, depending on what the patient's condition is, that we also provide it to them. Like if the woman is on oral contraceptives, she has to stop it 2 weeks before. She has to take alternative methods because we are worried about interaction and also the chance of a DVT post-operatively. So with every condition, you will find there are drugs that you would have to say, nope, you can't take this, stop that, and we give it to them so that they are prepared on the day and they have not taken those drugs. Others we'll just have, if it is an elective procedure, we would just cancel it. We would just cancel the surgery and put it on another day where he's more prepared for the operation. Do you have any particular drug in mind? The query is that way, or do you think
like I've read somewhere, like usually people undergoing surgeries, aspirin or the blood thinners are not given, like 1 week before the anesthesia.
aspirin, yes, if it is, if they're taking a higher dose, once again, they would say 7 to 10 days, you would have to stop it. Just like warfarin, I said 5 days. Aspirin, it is 7 to 10 days, because aspirin is the one which works on the platelets, and the platelets, they don't stick. So then again, there'll be more bleeding, more oozing. It becomes more messy. So to prevent that, we would stop aspirin as well. Yes. That's definite. We stop it. The common ones. Yes. Yeah.
There's one question: how much dose of anesthetic should be used?
Well, that is based on the patient's weight and their height and the BMI of the patient. So as I said, each anesthetic is tailor-made. Once a patient comes, we generally would have their weight in their, in their checkup form. So once we read that, so I would know, okay, this man is, let's say, 80 kilograms man. Our propofol dose is about 2 to 2.5 milligram per kilogram. So I should be giving him 160 milligram. So that's how we would do it. Normally, one vial contains about 200 milligram. So I would use the 200 milligram or 160 or titrate it according to response. So generally, it is all based by the patient's weight and height and the BMI. We have, all our doses are per kilogram, milligram per kilogram dose. So we have to keep track, especially for small children. We have to be very careful with them with doses, because they are the ones most variable, and we really, with the adults you can still get away with it, but with the children you can't, because they will just go down very quickly. So we have to really make those calculations before we start the anesthetic.
Yes, and in case of overdose of an anesthetic, what is supportive measures are taken?
Well, if there is an overdose of an anesthetic, what generally we do is, it's like symptomatic supportive measures. Basically, your kidney and your liver will eventually get rid of the dose. But what you have to do is, you have to keep them ventilated, you have to keep them asleep, and you have to manage their blood pressure. If they are hypotensive and their blood pressure is not picking up, then we would give vasopressors. We would shift the patient to HDU, high dependency care unit, where we would keep the patient under monitoring. We would wait till everything has been done, and then you would wake them up later on, because during all this thing happening, you don't want the patient to be awake. It will be very uncomfortable for them. And also, if there is, I did not mention the word anaphylaxis, but that has also happened. Suppose you give an antibiotic and the patient does not know, or he has not told you, and he gets an anaphylactic reaction. Then again, the same thing. We have to keep them supported. We have to keep them asleep. We have to keep them ventilated. And then we give off bloods to do all the tests then, because then the whole responsibility comes on the anesthetist to check out what was the drug that caused the anaphylaxis. So in that case, we would look for the histamine release. We would send it for the RAST, R-A-S-T assay, and we would take the blood immediately. Immediately the patient goes hypotensive and is literally kind of, bradycardic, hypotensive, unresponsive in front of you. First you settle the patient, take the blood, send it off. 6 hours later, again you take the blood, send it off. And the next day morning, again you take the blood and send it off. So you have got a record. And after that, once the patient has recovered, settled, then you have to advise the patient that they need to find out what have they got allergy to. Then we would send them to the allergy clinic, that is later on, where they will test and the patient will know for sure what agent or what is it that has caused me this reaction to anesthetics. It is rare, but can happen. You'll find that the patient suddenly becomes hypotensive, bradycardic, unresponsive. So, we have to deal with it if that happens. And we usually are ready with our agents and all.
Next question. In current hospital practice, how does the clinical pharmacist play a role in anesthesia administration?
Our pharmacists play a very big role, actually. They are very much involved, and we all our drugs and agents that we want, we have to take it past our pharmacy department. So suppose I say I want remifentanil, we have to go through what we call it the medicines management committee. I have to fill in the form and I have to submit it, and then I have to provide a whole set of study and research as to why it is important, for what reason I want it. And once we have provided that, then they would be giving us those agents. So usually our pharmacists are very good. They will give, if we ask that actually we think now a new drug has come, we would like to use it, but there is a procedure in place and you have to go through the method. And usually most of our drugs, we already have a list of it, and they keep track of our agents, amount we are using, how much we are using. And we do get letters from the pharmacy department asking, oh, you had a stock of so much, but we see that you have not used so much. So do you not want this drug? Do you want us to remove it? So they're constantly keeping an eye on our usage, on our way we are doing things. And so we have cut back, like drugs that are not necessary, we have cut back on it. And we have got a list of agents of drugs available from the pharmacy, and then they give to us. Yeah. And if I have a doubt regarding a dose or anything, then I will ring up my pharmacy department. Mainly for pain patients, if I have to use some new drug or something, and if I have to get it, then we have to go through them, or I can always phone them up for advice. So, and they do go around in the wards. Post-operatively, they're keeping an eye on the amount of pain relief they are getting. And if the patients are mainly in terms of interaction, they keep an eye out for, oh, the patient has got this, but the patient has been prescribed this. Then they will highlight it, and we will get the information that the patient has this particular condition, yet he has been given this thing. Like suppose a patient is on a MAO inhibitors, for their mental depression condition. So our MAO inhibitors, the monoamine oxidase inhibitors, they are a big problem with our fentanyl and no opioids. The only thing that we can give is morphine. So we have to check out, but that we pick up in our pre-assessment. So you see, there are multiple levels where things and problems of patients are highlighted. And then we tailor make again our anesthetic and avoid some things. And even if you miss it and it goes on, then the pharmacist picks up on it. Or else, in fact, sometimes they even cancel our drug. Suppose I write an anti-inflammatory drug and it's already 2 days past. On the third day, when the pharmacist is coming and taking their ward rounds, and they're going and they find, oops, it's day 3 and the doctors have not cancelled the anti-inflammatory drug. He's a hypertensive, or he's on warfarin, and the warfarin has been started, and he's still on the non-steroidal anti-inflammatory. They will just cancel it. So they work on charts and they do make a lot of changes. We might find, if I go to see my patient after 3 days, maybe the drug I wrote on the day of surgery is totally changed. So we work together. We work together as a team. Yeah.
For some claustrophobic patients, anesthesia is given during the MRI or CT scan. So will these anesthetics have any effect on the result of the MRI or the CT scan?
Not really, because they are claustrophobic, they need to be anesthetized. Usually the patients are not anesthetized. They go in for the CT and MRI like regular patients. They go, but I understand that MRI and it's like a tunnel and it's very, especially MRI, the magnets, they come close to you and literally you're there for 20 minutes and 20 minutes is a long time to stay still. If you're claustrophobic, I don't think you would be able to go through those investigations. So for that, we give complete general anesthesia. We have got very long tubes. We have got MRI, what do you say, compatible, MRI compatible anesthetic thing, where our machine and everything is outside the MRI room, and they're really long tubes, really long tubes. We go in, we anesthetize the patient, we connect him up, and everything has to be MRI compatible, because the magnets, once the magnets are started, then we don't want any metal to go flying around in the room. So everything is non-metallic, everything is made sure the magnets will not change, and then we are monitoring our machine and everything, because we are outside. We are not even in the room next to the patient. So monitor is outside, the machine is outside, everything is outside, but the patient is connected, and we only have the window through which we can see the patient to make sure he's fine. So fortunately, there are not many patients, most of them put up with it. Yes, but for children is the biggest problem. Children trying to do investigation, you have to keep them asleep. There is no way they're going to lie for 20 minutes like that. So for them, we have the really, really specific MRI compatible equipment.
What will be the regimen for anesthesia for COPD or asthmatic patient?
For COPD or asthmatic patients, the thing is that their airway, it is the airway problem. So if we can do a spinal, and we don't have to give all these agents which rely on your lungs to do the procedure, like if it is a arthroplasty or a knee replacements or some other such procedure, we will always say have a spinal. So that way we avoid any post-operative complications. Otherwise, the other thing is that we have to ask the patient that, have you taken your puffer? Make sure that they had their puffer, they are, they are not having a spasm as we start the anesthetics. Induction of anesthesia is not a problem because all our agents are, bronchodilators and other things. Ketamine would be good because ketamine is a bronchodilator for this patient as an induction agent. It is only when the tube is coming out and we are lightening our anesthetic, that's the time you have the problem of having bronchospasm and such reaction. So in this case, I would wake up my patient deep. Instead of lightening the volatiles, like we like to take out a tube when a patient is awake and we say, okay, open your mouth, I'm taking the tube out. But in this case, what we do is we keep the patient, we reverse the muscle relaxant, but we continue with our volatiles, keep the patient deep, take out the tube, and then by hand, we will ventilate and slowly cut off the volatile. This is to avoid any reaction of bronchospasm, laryngospasm, hiccups post-operatively. So that is how we have to manage, especially for COPD and asthmatic patients. And give oxygen. Afterwards, you always have to supplement with oxygen because these people's lungs are not good. So they need more oxygen than any other regular, fit, healthy patient.
Any more questions? So I guess there's no more questions. So we'll proceed with the vote of thanks. So it's a great honor and privilege to propose the vote of thanks. First and foremost, I would like to thank our honorable speaker, Dr. Susmita Oomman, for gracing this occasion and spending your precious time all the way from London. I'm also entirely grateful to our principal in charge, Dr. Atmaram Pawar sir, our president of IPSF Pune, Dr. Ayush Gandhi, Vice President Dr. Shubham More, Secretary Monish Thorat, Joint Secretary Noor Sheikh for organizing and arranging this webinar. I would also like to thank all the participants who have been active listeners throughout. And I would like to conclude by saying you are braver than you think, stronger than you seem, and loved more than you know. So now I will request everyone to kindly switch on their cameras. We'll take a quick photo. Ma'am, can you please stop sharing the screen so that we'll have a good view of everything? I request everyone to switch on their cameras. Are we done? So thank you, everyone. Thank you so much, ma'am. So as always, stay safe, stay healthy, and stay happy.
Thank you. Thank you very much. Thanks. Bye-bye.
Bye, ma'am.